Hope everyone's well on this rather warm afternoon. Is there anyone out there? Abby, are you there? Right. Okay, I think we're coming up to start time now, and we'll start to record and welcome everyone to the 65th meeting of the Oxley's Council of Governors. As I say, big welcome to you all. We'll start with apologies for absence. Do we have any apologies for absence?
We do, Andy. We've got apologies from Francis Murray, Cara Lee, Graham Turner, Mark Ellison, Raja Rajendran, Denise Scott McDonald, Rachel Claire Evans, and Catty Meyer will be joining us a bit later at 3:30.
Okay, lovely. Thanks very much. We'll go to the minutes of the last meeting. Sing out if anything you want to draw to my attention. Page 1, page 2, page 3, 4, 5, 6, 7, 8, 9. If there's nothing anyone wants to draw to my attention, we'll move straight on to any matters arising from those minutes. Have we notified of anything, Joe or Sally?
Apologies, have we just talked? I was slightly late joining the meeting. Was that going through the minutes? Because I did have changes to the minutes.
Oh, it was, Azra, and it's apologies, we were very quick off the mark today. But anyway, so yes, what have you got, Azra?
So it's you'll not be surprised to hear it's in the finance sections. And just a slight change to the wording. Sorry, let me just flick back and get to the changes. Apologies, everybody, for me scrolling now madly through the minutes. So the first one was in section 7, 5th paragraph down. So it's talking about the technical adjustment. Now, I think from memory, this was the bit where we were referring to the IFRS 16 adjustment, which was the changes to how leases are accounted for. And there was an estimate of a cost pressure of 0.3 to 0.5 million, which was accounted for within the plan. So it was that, it's not the fact that there was funding associated with that. As a postscript, that's actually now come out at something like 250,000 rather than those elements, and we'll finalise it out in September. I am happy outside of the meeting to run Joe through just a revised set of wording, but that's broadly where that is. Then 1, 2, 3, 4 paragraphs beneath that, where we refer to the 5.88 million in efficiency savings. They're all recurrent. But I think we recognised it's been set as a recurrent task, but the directorates may actually end up delivering it in a non-recurrent way. But that then does lead to issues for next year. That was that. And then there was one other change, I think. Let me just scroll down the minutes until I can find it. Apologies as I'm going a bit slower here. Oh, I can't find it. I'm going to just run with those two.
Okay. So if you'll talk to Joe on that one and put in the appropriate change. If there's nothing else from anyone else, good. Thank you. So we go to any matters arising. I haven't been notified of anything on there. If no one else has either. Sally, please.
I could just update because most of the matters coming up in the agenda, but John Crowley put himself forward for the audit working group. Thank you very much, John. And that will be meeting in due course. Thank you.
Thank you. Well done, John. Thanks very much. If we go on to item 4, so this is when we're looking at the reappointment of Suzanne Shale. We're looking at my other commitments, and I think we're doing an update from Sophie and Jim. Are we not, Sally? I've got that right on there. Yeah. Okay. All right. So if we're going to talk about Suzanne, then so Suzanne, if you were going to leave us, and Sally, have you got a contact to invite Suzanne back into the room?
Suzanne, I can email you to get you back in. Will that work for you?
Yeah, that'd be fine. Thanks, Sally.
Okay, thanks very much, Suzanne.
Right,
So
see you soon.
leave us for a moment, and then we'll be back to you quite soon. Thanks very much. Suzanne's term of first 3 years comes to an end soon. As you see in the paper, we've had the 360 degree reports from people, plus the fact I have spoken to Suzanne on a couple of occasions to talk through the results of that and other matters. And this was then went to the reappointments. And Sue, did you want to say anything yourself at this stage, Sue Salter?
Only that I think in my dealings with Suzanne, it's been really good. She's really helpful, positive, always good with sensible advice and comments. And I have no problems in putting her forward to be reappointed. Okay,
thanks very much. So the committee sat on the 6th of June to consider her reappointment. And I certainly think she's eminently reappointable. I think she brings a different dimension to the board, particularly from her ethical experience and professionalism. And she's quite challenging in a number of ways, but in a very positive way. And I think she's made us think and rethink on a number of issues in a way that I think has been extremely helpful. She's been very active around the trust, particularly paying visits to the prison directorate at the moment, and bringing her experience to a number of different parts of the organisation. She was chairing infrastructure and did a really good job there, I think, and has now moved on to take on the quality improvement. And she, as I say, on each occasion, she does bring a quite a new and refreshing slant to the work that she does. So the committee sat and recommends to the Council of Governors that she be reappointed for a further 3-year term. And in order to do that, we need the agreement of the Council of Governors. Does anyone have any observations to make? In the absence of any observations, then John, please.
Yeah, just to say, Andy, I was on a serious incident panel with Suzanne, and I totally concur with all your observations, really. Different perspectives, challenging in the right way, see things in a very broad perspective. So I have no problems with ongoing, really.
Thank you, John. I think she brings a really good, as I say, I can repeat myself, but that different perspective, that different slant, and a good challenge that makes you think about things and look at them sometimes with that different and refreshing approach. If there's nothing else from anybody else, I will take it that in the absence of anything else, that the Council of Governors agrees to reappoint Suzanne Shale as a non-executive director for a further 3-year term. Are we all agreed? Yes, it looks to me that we are all agreed. So Sally, ask her back in the room, please. Thanks very much on that. Yeah, I have been back over to me now. I was asked by NHS London to take on the chair of London Ambulance Service. I didn't initially apply for the job. I knew it was being up for a new chair, but after some discussion with them, they have appointed me to the role to start on the 1st of July. Clearly, that's another considerable commitment. Both of these roles are part-time, but the Remuneration Committee will sit soon to look at my own terms and conditions and look at the contract as far as I'm concerned and as far as Oxley's is concerned. And my commitment is I will give full value to both organisations, and if at any stage it appears that I'm not or I can't, then we will think again. I have 2 years left on, 2.5 years I think left on my contract with Oxley's, and personally I'd like to see that through, but only if I can deliver a satisfactory chairing of both organisations through that time. We will at some stage or other have to think about advertising for a new chair. Things had changed in the world of chairs. There's lots of people now with multiple roles, 2 and sometimes 3 different trusts that people are taking on. And there's some interesting combinations of trusts that are coming up at the moment. And there have been some challenges about getting the right people into those roles. So Once the remuneration committee has sat on that, then it's the appointments committee. So once the nominations committee, I should say, once the nominations committee has sat, then we'll report back to the Council of Governors. Anything to add on that, Sally?
No, and we have included it in the report in the annual report as well.
Okay, thanks very much. Anyone got any questions for me on that? And if no one to ask now, I'm very happy. John, please.
I'm just thinking, Andy, is there any potential conflicts of interest between an ambulance service and between a mental health?
I don't think so. I've been thinking about that, and obviously if there are, I can declare, but it's hard to see any direct one. I think if I was an acute hospital chair, I think one would say quite possibly, because of the role of the acutes in A&E and the, I wouldn't say conflict with LAS, but the interface between the two, which is very public today in the report that's just been published about waiting times and ambulance delays, things like that. It doesn't directly affect us many ways as Oxley's, as far as that's concerned. But if any of those do, I mean, there's the ICS relationships. Obviously, I will have a role within South East as Oxley's. I will also have a role across London with the 5 ICSs. Ambulance chairs and chief execs are not represented formally in any of the 5 ICSs. Quite interesting that. But no doubt I will, and I have been invited already to Northwest and Southwest to talk to them. Just talking about LAS for a moment, it's a London-wide body that needs a London-wide response to lots and lots of issues. And that will be one of the issues that crops up. But if it does crop up, particularly say in South East, I'll be very clear about who I'm talking for. And my role within South East will be to talk for Oxley's, because that's why I'll be there as the chair on the partnership board. Anyway, there we are on that. So did I see another one come up? Does see Michael come up? Yes, Michael.
Yeah, sorry, I was just going to say I'm fully supportive of it. It sounds like a great idea, and if anything, no, ambulance services do need a mental health perspective, given demands in the country for not just now but for years. So maybe you can.
Yeah, it is this morning, and those issues do intertwine in the sense, and the many staff very much sort of saying to us as a mental health trust, what are you doing about that? Because of people waiting within A&E with mental health patients, and that does impact, of course, on the delays, the general delays. And we are as a mental health trust, we're a minor part of those delays. But it is something that there is a matter there for us about the way that mental health patients are treated within A&E, and that does tie into this whole logjam of GP appointments, 111 services, 999, ambulance, A&E, acute wards, round to discharge. It's a really interesting, I was going to say flow, but in the places I've visited recently, I haven't seen much of a flow. It's a really, really challenging time. So I'll update our colleagues further on that for future meetings. If anyone's got any concerns or anxieties, usual rules apply. You can contact me at any time you like to chew them over. I want to be absolutely upfront with everybody about my commitment to Oxley's and my commitment to the LAS. And as I said just now, if at any time I think this isn't working out, then I shall come back to you and we'll think again. If everyone's happy with that, I think, Sally, we move on now for Sophie and Jim, don't we, to give an update on how they found the first months of their role as new NEDs.
I know Sophie joined us. She is calling in from a conference, so there may be some background noise, and Jim is here as well. But we thought, seeing that the Council of Governors appointed Sophie and Jim and start in January, it would be a good opportunity to give you a quick update on their first 6 months. So Sophie and Jim, if you'd like to join.
Can you hear me okay?
Yes.
Yes.
Okay, interestingly, when you speak, I can't hear you, but I can see your mouth move. So hopefully we'll be able to do this. Okay. Jim, do you want me to go first?
That's fine, Sophie. You go ahead.
Okay, thank you. Yeah, so the first 6 months have been really interesting. A real challenge at first because there is so much to learn and so much to take on board, and so many meetings in particular to try and put in diaries when you have a full-time job. But I think I don't know if Jim's the same, but I'm feeling like I've achieved that balance now. So what I've been doing over the past 6 months, the first few months were that steep learning curve where meeting executive colleagues, meeting non-executive colleagues, learning more about all the areas of work that Oxys covers. I'm the non-executive lead for children and adolescent mental health services. So I've been out and about with my executive lead, Rachel Claire Evans, and we had some great visits. We've been to Bexley, we've been to Greenwich CAMS, we've been to speech and language therapy over in Bexley as well, and heard about some really interesting work. And I have to say the best visit of all was the one where we were able to talk to a patient, a mother and her child who'd come along with a classroom assistant for a speech and language therapy assessment. And that really gave me a flavour. So that's what I've been trying to do. Obviously, at board level, you get one picture, but I've been trying to get out and get that frontline staff picture and that patient picture as well, and try and put those three things together. So unlike Jim, I'm lucky I'm not chairing any committees, but I'm involved in 4. I sit on the Quality Improvement Committee, Partnership Committee, Health and Safety Committee, and People Committee. So what I've been trying to do with all of those is really focus on bringing my professional and lived experience, which is primarily in co-production and representation of parents, patients and carers, and also of how our organisation works with the voluntary and community sector. And that's particularly important now as we have to focus on health equalities, and also through our work with the ICS, which focuses more broadly on health inequality across the whole of the ICS footprint. So for each one of those committees, I've been trying to bring that perspective, bring that challenge, and try and introduce in some cases colleagues to the idea that the voluntary and community sector is a great resource that's there for us, but does have to be paid for and does have to be treated with equity and parity as well. So I hope that's given a flavour of some of the things that I've been working on and my interests. Going forward, I'm really interested in looking at how we get more assurance at board on patient involvement in co-production that's meaningful and not tokenistic. That's a really difficult thing to achieve, and hardly anyone's done it across the country. It would be great if we could do it at Oxleys. So that's, as I say, that's what I'm really looking forward to doing more of. And I'll hand over to Jim, but happy to take any questions now, or if anyone would like to get in touch with me directly afterwards, equally happy. And I'm afraid I will have to duck out straight after this. I am at a conference, though, which is talking about multiple disadvantage and how people with multiple disadvantage access secondary mental health services. So it's really relevant, and that's the kind of thing. And I have talked about Oxleys here as well, so I am flying the flag, and I'm not ducking out to go and do something else. I'll shut up now.
Thank you so much, Sophie. Any questions for Sophie before she has to leave us? I mean, if not, thank you so much. I mean, it's really interesting to see how you found the first few months, and obviously we have our one-to-ones. And I know you'll let us know if there's anything we can do to improve that induction or add to it, because I know just how challenging it can be to try and understand the complexity of the organisation. It takes an awful long time, but I'm really happy with the way things have gone so far. So if there's nothing else for Sophie, thanks ever so much. Be interested to get some feedback on the conference sometime, and let's see how that goes. Thank you. Jim, please.
Thanks, Andy. Good afternoon, everyone. Really pleased to meet you. My name's Jim Shake, and my background is somewhat different to Sophie's. I come from an engineering, very hardcore engineering technical background, focused on product design and development for a while. But last 20, 30 years, I've been running my own businesses. So I've got quite, I fell in love with entrepreneurship and sold my last business in 2019. So we sort of grew the business from nothing to selling in 20 countries around the world, and I managed to get out just before COVID, which was really good. It was a good result. In terms of my roles at Oxley's, as Sophie said, I'm chairman of infrastructure, which I'm finding really interesting. With an engineering background, I mean, I do understand the technical items, and it was a really good introduction to how committees work and what they do. But I'm really interested in the capital expenditure, the structure of that, how we invest our capital in both the estate side, but also the infrastructure, the digital infrastructure, which is really, really important as we go forward. And so hopefully I am going to get more involved on that side, and how we can use the digital experience to enhance the experience of our communities with Oxley's. I'm also a member of Audit and Risk, which I particularly enjoy, with Steve as chairman. That's close to my heart. I'm on a number of boards, private companies, and that's where the meat and drink of what we do normally is. I am quite impressed with the BAF and how that's managed, how the risks are cascaded through the committees and down. So I think there's a high level of assurance that the whole organisation is now getting more and more focused on risk, which I think it has to be, and all the different risks that we have to work with. And I'm also a member of Performance and Quality Assurance Committee. To be frank, I've found that one the toughest, because it's further away from my background, but fascinating in terms of the measures, the metrics, how we measure our performance, how we go forward, and how we then drive the transformation of the business through some of these measures that we're bringing up through the committees and up to board. I think in terms, and also I have I'm starting to become more interested in the prisons. That's my focus. I went to see Wandsworth last week, especially after the transfer from SLAM to us, and I was really, really impressed with what's happened there in such a short period of time. I mean, I'm not sure how aware of you are of the situation when we took over. I think we only, of the 30 staff that were meant to come over, only 9 came over from SLAM. And so Lawrence and his team have had to work really, really quickly to put some safe staffing levels in place. And they've done so in a very short period of time. So that's quite an achievement. And when I went around the prison, I mean, it's my first visit to a prison, so it's quite a shock, to be honest. I think I was saying to my 19-year-old, you need to visit, really need to visit these places. It's an eye-opener. I was really taken. I didn't have formal meetings with the staff because it was much more of an introductory tour, but we met staff in the corridors, in their rooms. We went to see them rather than to see me, which is really good, and sat in a really informal space. And they were all, to a person, really positive. I mean, there was 3 sets of staff there. One set were the new staff who came in within weeks or months, and they'd already got their feet on the ground and moving forward. There were staff who were coming quite a long distance from Kent all the way to Wandsworth and making that journey, and really positive about the impact they're making. And then obviously there's a 2P staff who are getting used to the Oxley's way, and to a person I met lots of smiling faces. So I think that's a really excellent introduction. As Andy said, it's been quite a steep learning curve. So sort of how's it been going? Quite a steep learning curve. I can assure you that Andy works his Neds hard. So it's been a lot of work, especially moving from a sort of private entrepreneurial business to large public body, from technology to health, and from private company sort of financial type aspects to a unitary board. But I hope in that I can bring a slightly different view to what's going on at Oxley's, in terms of I'm quite interested. I'm going to start to work with Neil Spring, I hope, Neil, on the customer complaints side of things, because I come from a customer service background as well, and that'd be really interesting to understand that. And I'm really interested in this flow, this very topical flow now, and the flow of how things move through our system. So what else can I say? Yes, I think I've been taken by the positive culture that exists within Oxley's all the way through, and the desire to help our local community. I think the issues coming forward obviously are going to be the ICS and how that all pans out, especially on the financial front, which I have a particular interest in, and also how we deal with staff vacancies and retention, which I think is a core issue that will affect everything across the board. And again, the graduate scheme has been excellent. I think hopefully we won't talk about it too loudly so no one else knows, but I think that's an excellent way of going forward. So I'm looking forward to doing more visits. I've got some estates visits and some infrastructure visits now planned in the next couple of weeks, and hopefully I can tell you more in the next 6 months.
Thank you, Jim. And any questions for Jim? I think Sophie and Jim have just bring again some very different approaches, which is extremely refreshing. And Sophie, from her sort of lived experience approach, from her experience working with the lottery and many third sector groups, and Jim, you know, from that engineering is actually, I think it's been really helpful. There are times when the way that you look at a problem, you know, when you talk about a supply and demand problem, and it sometimes helps us, I think, re-clarify some of the issues, and it blows away some of the clouds, I think, from some of the debates sometimes. So I think that brings a huge strength into the organisation, which is why, you know, the Council of Governors have selected you and Sophie, and I think in general, I think the Nhs bring very different approaches from all sorts of different angles, which I think is good. Michael, please.
Yeah, hi Jim. Yeah, I was wondering, what difference do you see between the boards that you've been on in the past? I suppose the stereotype is private sector versus NHS, but what differences do you see between how we operate and how other boards you've been on operate?
That's a good question. One thing is by definition, so this is a unitary board, and so the boards I'm on normally are not of that type, and so the responsibilities are quite different. Okay, and to be frank, quite a lot of the time spent on the board of a private company is spent around the finances and the budgets, etc., and budgeting and strategy. And I know Andy and I have discussed in passing about the mixture of strategy and operations within an NHS board, and we go into in the NHS side a lot more detail than I would have expected in a private company. I mean, normally the execs get on with it. We deal with strategy and we deal with the finances and the overall wrapping. As I've got into the role, I can see why, especially Ockenden report. I mean, I think we had a really good meeting yesterday at PQAC when we went through a very excellent review of the Ockenden report, and it shows you there why we have such a grip on what's going on, because we can't let anything like that, and some of those elements occur within Oxley. So that's one side of it. The other side of it is that everyone pulls together. In other boards, you can find a lot of conflict, or can have conflict, and different agendas and a different focus. Whereas here, we are here to help our community, and that comes through. And so it's all working together rather than individual fiefdoms. Hopefully that gives you a flavour.
Yeah, absolutely. Thank you, Jim.
Yeah, thank you. Good question, Michael. But as I say to all our new Nhs, just because we do it in a certain way doesn't mean it's right. I think that's the joy of bringing in fresh approaches that might challenge the way we do things, because it is easy to get sort of stuck in a particular way, and it's helpful to look at other organisations to see how we might refresh our approach. If there's nothing else or anybody else on there, real big thanks, Jim and Sophie, for that. That's really helpful. I'm going to come on to item 5 now, which is Chief Exec's report. Azra, you were mentioning that you've got to go at 4. So I just wondered if, Sue, if you're happy with that, after we have Ify's report, if we go on to Azra, and then we'll come over to you on the Lead Governor report after that, if that's okay. Ify, please.
Thank you, Chair. Forgive me, colleagues, that my report wasn't in your bundle, but I hope you received the copy of the report. So I don't intend to go through every single thing, but I just wanted to highlight a few things, if I may. So the first, of course, which has been touched on both by Andy in his visit this morning and by Jim, is the pressures that continues across the system. I think everyone will know right now, all you need to do is listen to the news, that there is pressure across acute, pressure in primary care, and we are no exception. And the pressures we're feeling cut across pretty much all of our services. And it's further compounded by some of the challenges that we have with vacancies. Some of the vacancies predated the pandemic. And then since the pandemic, there's been the additional issue, which is about how staff feel exhausted and their morale is rather low. So we've been thinking about how we can address all of these issues. One of the things that we're certainly doing is making sure that we support our staff. We looked at the staff survey results from just late last year that compared how all of the trusts across Southeast London were faring with respect to staff morale. And there's no doubt that our staff, the morale amongst our staff is very low. Similarly, there's no doubt that they all don't quite feel safe and healthy. And so we've got a lot of well-being support that we are putting on for staff, making sure that they know those are there, that they're accessing them, because it's really important that we address this, knowing how this can impact the quality of services they provide. The other thing, of course, is that we are aware of the challenges the rising cost of living is having on our staff, particularly some of our unqualified frontline staff. And so we're talking with colleagues across Southeast London to see whether there's anything we can do jointly, so it won't be one trust doing something and the others not, to support staff. So far that hasn't yielded much, but we're still trying to work that through. I wanted to also draw attention to the Council of Governors, of all the activities that are going to be coming on over the next 3 or 4 weeks. We had one really interesting one today to celebrate the Gypsy Roman Traveller History Month, hearing from some really, really interesting groups, and in particular one of our lived experience staff who through his own personal experience kind of helped us to understand what it feels like to be someone from that community, what the issues are, and of course that should help other staff from similar backgrounds, and perhaps more importantly would help us to start thinking about how we provide services to such marginalized groups. But there are lots of other activities that I'm sure Joe and Sally will share with you. I just wanted to touch on COVID-19. So of course, you know, we are now in level 3. I was at a chief execs meeting a couple of days ago when the director for public health for London told us that the COVID rate was about 400 cases pre the bank holiday, and this week it's gone up to 4,800 cases. It's thought that the level of mixing that occurred throughout the bank holiday may have contributed, but I think that just signals to people that this stuff is still out there, hasn't quite gone away, but we hope that it will remain quite subdued as it has been over the last few months. You will of course have heard about the Monkey Pox outbreak. That's increasingly becoming a matter of concern. The WHO has particularly raised concerns as many of the cases are in Europe. In London alone, we have had an increase from 8 to 10 a week or so ago to 40 cases this week. And so there is a plan to begin vaccinations, particularly as the largest proportion of those who have monkeypox are gay men. So there's a proposal that they are vaccinated in the first instance. The good thing, of course, is that we don't have that many in intensive care units. I think we've got 8 in ICUs and 300 cases who are 8 of the 300 cases who are managed in London. So the numbers are shooting up from 8 to 14 1 week. About 300 cases already in London. So I don't intend to talk about the ICS, partly because we had a session on this, and Sue and other governors did grill and ask lots of really interesting questions. I'm happy to take further questions. And then the final thing I just wanted to mention, if I may, which was touched on earlier, is the Ockenden report, which the exec have thoroughly reviewed and put a paper through to performance and quality assurance yesterday, which I was glad to hear Jim commend. And that's going to come to the board next month. We will, of course, be happy to bring that specifically to the Council of Governors at a later date, if that's required. Happy to take questions on all the other matters in my report. Back to you, Andy. You're on mute, Andy. You're on mute.
Yeah, deliberate mistake of the day. Thank you. I can't. I've got a hand and I can't see the name. Sally, who have we got?
Yvonne.
Yvonne.
All right, Yvonne, over to you.
Thank you. Yeah, I just wanted to ask, you point out, as you say, all the headlines in the news that are affecting Oxley's as much as everybody else about the staff pressures that we have, recruitment issues, etc. And I really wanted to ask, is there any hope on the horizon, or is this going to get worse before it gets better?
Yeah, so one of the things that we are doing in Oxley's, of course, is trying to find alternatives. You may have heard Jim talk about graduate scheme, where we've decided that we're just going to recruit bright graduates and see how they can help us to relieve professionals, and we've had very, very good response. I think the interviews may well have happened. The last time I talked to Lorraine, maybe 10 or so days ago, she said we had over 100 applications for something like 12 or 15 positions, so that's one thing. Apprenticeship, we're trying our absolute best. So we're looking for alternative ways. Now, your question as to whether it's going to take a little while, I think it will probably take a little while, because the vacancies are really about qualified people, and qualified people take a bit of time to train. So if we can relieve qualified people of stuff that unqualified people can do with support and supervision, that would be a start. Whilst we're also trying to recruit, we're all fishing in the same pond, as they say. Staff are moving across from Kent to us and from us back to Kent. We'll continue that. And then, of course, we're also looking at international recruitment, but there isn't a great deal out there, in terms of places we can go to recruit. And even when we do, they often require quite a lot of support, different systems coming to the NHS. So to summarize, I think it's going to take a little while. It is going to take a little while. I also have a meeting that I was at a couple of days ago of chief execs. We looked at the data across England and also London. It seemed like we had a 15% increase in terms of recruitment and a 13% exodus. Either people retiring or leaving London, etc. So there's this flux, that really, it's almost as if you're running to stand still, because as you're bringing in people, people are leaving. So I think you'll probably hear this for a bit longer.
Thank you. John, please.
I think, Andy, I'm just wondering, or as a user of the new Elizabeth line, whether in a way that could be incorporated into a promotional material, certainly for Greenwich, isn't it? Because it's very accessible, very fast and very speedy for people in the wider London area, really, to access Greenwich for now. Just a thought, really, but
It cropped up yesterday, funny enough, when I was at Wandsworth yesterday, and just talking about movement of staff, because as you know, prior to Elizabeth line, or still even now, east-west movement across sort of outer London is not that brilliant, and it does bring Woolwich and Abbey Wood and all those into it a lot more than it would have been in the past. But what I found, echoing the points that Ifrs made on my recent visits, I mean, there's nothing unusual, nothing you've not heard before, but it's been demand, complexity of demand, and shortage of staff has been, I would say, the theme that runs from just about everywhere I've been visiting. I would say, I think even in those parts of the organisation under extreme press, I'm always extreme pressure. I've always been impressed by the enthusiasm and energy of the staff, but it is a very, very tough time. But that, I think, across the whole of the NHS right now. Is there anything else for Ify? If not, thank you so much, Ify. Thank you very much indeed. I think Suzanne is back with us now and has been back with us for a while. Anyway, so Suzanne, congratulations. The Council of Governors have decided to reappoint you for another 3 years unanimously. So thanks very much for everything you've done so far, and look forward to working with you again over the next few years. Thanks very much indeed. We'll now go, if we don't mind, we'll go over to item 7 with Azra, please.
I just wanted to check whether or not Joe wanted to say anything on finances first.
I can do, Azra. I think, as the Council of Governors will know, this agreeing the plans for the year that we are already in and moving through has been a lengthier process than we've seen for some time, very, very closely linked to the ICS, and is, I think, something that we're going to see in the future. Much more than we have, certainly over the last few years, when obviously the COVID arrangements that were put in place from a financial perspective ease things, obviously not from an operational perspective. So Azra, you're going to give us the latest update, and I think just over to you to sort of explain where we're at, I think.
Okay, so just before we go into the next slide, a little bit of context. The last time I spoke to the Council of Governors, we were in a position where Oxley's was at break even, i.e. our expenditure lived within our income that we had been allocated. But as an ICS, we were in quite significant deficit. Since that time, NHSEI came back and said that's not good enough. They said it to every ICS in the country and said you must all get to a position where your costs are within the amount of income that you have got. And everybody was sent away to redo this. And therefore, what was previously the final version of the plan at the 28th of April changed to be the final version of the plan will be the 20th of June. And those plans, by the way, had better come back as break even. So what I've got on the next slide is I've tried to put everything, the entire ICS position and the trust position onto one slide. And apologies, I didn't get it in the pack, but this literally arrived about a minute before the meeting started into my inbox as we were trying to do that piece of work. So Sally, if you take me through, this looks like a plethora of figures. I'm going to talk you through what this slide shows, and it should hopefully become clear from that. What you've got on the left-hand side is all of the organisations, the NHS organisations within the ICS, or as it will be known as, the Integrated Care Board going forward. So it starts with Guy's and St Thomas's, then you've got King's, Lewisham and Greenwich, ourselves at Oxley's, SLAM, the CCG with the remainder of their commissioning element, and then you've got the total ICS position at the bottom. What we've then got through is a series of columns as we move from the left-hand side to the right-hand side of all of the movements that have got us to the final bottom right-hand position of a break-even for the ICS. And I'm going to just now talk you through some of those. So the first column is what the position was as at the 28th of April. And you can see at that point, Oxley's was the only organisation in the entire sector that was reporting a break-even position. The rest of them were in deficit to the tune of £132.5 million. What we then did is we went through a period of challenge with each one of the organisations, and they were asked to further improve their positions. And all organisations, you can see in the second column, improved their positions from that previous position that we had had to the tune of £58.7 million in total. The figure that you see there for Oxley's is what we effectively did is we looked at our cost, we looked at how much we thought that was going to forecast through to the end of 2022-23, and we actually said, we think we can do and manage our position with you giving us less income from the system top-up arrangements. So we will return both that income and that cash to help other organisations within the ICS get towards a break-even position. And that meant we didn't need to shift the £13.5 million SIP target that I took you through at the last meeting. We then received some further funding and some dispensation from NHSE around two factors, which is the next column that adds up to, she says now squinting at the screen, the
73.85. You're mute now, Azra.
Apologies. Pot number one was made up of the fact that NHSE and nationally they recognised that when they had originally set the planning guidance, the rate of inflation, which at the time had been based on the September 2021 rate of inflation, had been far outstripped over that period of 6 to 7 months with real actual inflation. So they have basically handed out some additional funding to all organisations nationally to help with that issue. The second issue was they had assumed in the planning guidance that COVID would have finished because they set the planning guidance round about September time and set the financial envelopes round about then. They had thought that we had got through the second wave of COVID, everything should be going back to normal, and therefore that's the way that the planning cycle would work. However, Omicron then hit nationally, and that has impacted on the elective recovery, which is what ERF stands for in here. And what they recognised is that the Omicron variant was going to impact on the elective recovery for acute trusts in particular during the course of Q1, so the April to June period. And they gave out further dispensation to those acute organisations to recognise that their beds would be filled with COVID patients and therefore they couldn't actually fill them with elective patients coming in to address some of those waiting times. So that's the kind of second dispensation element. We then had the position net of all of those improvements, etc., coming to break even. But you will see that column that comes to the zero at the bottom still had a range of differences in organisations in the fact that what we had got at that point was a number of organisations that were in a position where they had they were still effectively in a deficit position. Other organisations that were still putting more money into the system to help other organisations out. And that is effectively the figure that you see that moves the Oxley's position to 6.07, where we had given some additional funding through to again help other organisations that were in deficit. You can see that Guy's and St Thomas's, so the figures in red and with negatives in front of it, is organisations saying, here is our contribution to help with the ICS position. The figures where they are black are the organisations that were really struggling with their finances. So you can see every organisation effectively was putting more money into the ICS position, apart from King's and Lewisham and Greenwich, which were still continuing to struggle and were in deficit position. That position continued and they said, well, we still not quite managed to get to a finalised balanced position, which is the next column that adds up to a £10 million deficit. And that was kind of taking into account things like certain organisations having already identified we've got excess inflation over and above the funding that we've got, or we have got other further cost pressures that we had expected national funding for, which did not flow through. The big one of those was the fact that King's had opened up critical care capacity, and they had expected that to be funded, and that was not funded. It was about £20 million. And therefore they had a £20 million hole in their overarching plan that they could not fill internally without some degree of support. So once again, everybody went through the position, and you can see some of this is picking up the money that had been distributed prior to the 28th of April. So we had already put into that pot £2.1 million that we had returned back, and the CCG had already put some further money into the pot in that period before the first column figure. That then gave further additions coming through, and we then see the total distribution column of all of the money that has flowed through, with the red negative figures being where organisations have given up funding to help the ICS position, and those figures in black being the organisations that were effectively the recipients of that funding. And you can see there is a split between everybody that was non-acute funding some of the issues and the deficits that the three top acute organisations had. Once that final distribution had been made, you get to the final column, which gets us to a break-even ICS position with all organisations with a planned break-even position. So that was landed on effectively at the tail end of last week. Each organisation has now revisited their internal plan, submitted it, and this will be the consolidated position the ICS will submit and on the 20th of June. What that's tried to summarise is a number of, well, a very large number of meetings and a huge amount of work that has been done on behalf of each one of the organisations that has involved very close alignment and discussion with all of the organisation chief executives and their CFOs and DOFs, and then that we have gone through internally within the trust at both executive level, business committee level, and trust board. But the timings have been, it's been very fast moving, so the timings haven't necessarily followed the normal flow if we at Oxley's had been able to be in charge of what some of those timings and flows were. And I hope that has given the Council of Governors a summary of what was a number of very complex slides that we've tried to take you through in terms of the journey from the last time I came to Council of Governors to what the position now looks like. Sally, do you mind taking that down so I can just take any questions? And I can sort of see people. And Jo, do you want to come in? Is there anything you wanted to add before we go into that?
Yeah, thanks, Azra. I mean, I think your presentation has really shown that it has been a really difficult and long and complicated process. And as governors can see, intrinsically linked to what's going on in the other trusts in the ICS, which we've had a risk about this for some time, and it's really become very focused during this process. I guess what would be useful for you to say and give your view on is there's been a number of changes to our plan. So our plan isn't where we started. How are you feeling in terms of our ability to achieve this plan this year? I think that's helpful.
I think if people cast their mind back to when I'd gone through the detail of our internal plan, there was a series of blocks that we'd said of how we thought we would be able to achieve financial balance. The block which I think has got greater, but that comes with a set of challenges, is the vacancies that we are currently facing. So Jim had mentioned the fact that we'd taken on Wandsworth. We had very high levels of vacancy when we took that on. We've got a similar issue with Kent prisons, where we've taken those on, and in certain areas, the level of vacancy that we have taken on was very significant, and that has effectively led to greater underspends in the earlier part of the year. We've gone through month 1, and having factored in at that point how much money that we had put into the ICS position, we were at break even. The business committee will hear, and the formal exec have already heard, that for month 2, having factored in the final amounts of money that we have got and we have effectively given forward to the ICS position, we are again at a break-even position. Now, when I say break-even, we have deferred £800,000 worth of money, i.e. if we hadn't deferred that money, we would have been in a surplus position. So I think we have got sufficient capacity. Unfortunately, due to vacancies, and this is not about holding back on filling vacancies, this is an inability to permanently recruit or fill those vacancies through bank and agency, which means that we will non-recurrently hit this figure. I think the concern I would have, Joe, and it reflects the red-rated Ifrs that we've got, is the sustainability of that, what that will then mean for 23-24 and the years beyond.
Thanks, Azra. So I think, what I take from that is, in terms of our ability to achieve the plan, we are feeling confident. I have to say, largely for fairly negative reasons, because we have vacancies and we're struggling to recruit them, although we expect that to improve. The focus for us then is how we can generate further savings so that we can enter 23-24 with perhaps a different run rate. I think also it's fair to say, Azra, that we might expect further pressure during this year, because we have a view that some of the other trusts in South East London may well struggle to achieve their plans. Is that still right in your view?
That is right. So although what we have there is a break-even plan, if you look at the risk profile against that plan, it's currently sitting for the whole of the ICS at about £140 million. And we've got an ICS Financial Recovery Board on Friday, where we will begin to discuss some of that risk profile. The good thing about whereabouts we are now is we move off planning, which is all about bits of paper and deciding on a bit of paper whereabouts we are, into delivery. And I think this is going to be where the hard work begins. The piece of work that I've just talked about in terms of that deferred income, I do think that we will be asked to make further contribution into the ICS position, because nobody had to report month 1, but the highlights for month 2 that are beginning to come forward are a number of those organisations are off plan. So I do think this is going to be a very, very tight year financially. And because we as an ICS are held to account collectively, I think there will be ongoing discussions to be had.
Thanks, Azra. I've got nothing else to add at this point.
Zara, please.
So I think you've just answered my question, Azra. So I was going to ask how likely it is those 3 acute trusts will hit the targets and what's the implication for us. And it sounds like the implication is we may be asked to cough up some additional savings to fill the gaps that may emerge in their plan. I guess we're still to really find out as we go along how those discussions might happen and to what extent, we'll be held fully kind of accountable for that. So I suppose that's a moving feast throughout the year for us to keep an eye on.
I think that is true. What we have been very clear about from the funding that we did give up is that was non-recurrent. So what we've said very clearly as an organisation is, because of where we find ourselves this year with the level of vacancies, we can help you out, ICS, to the tune of this amount of money. However, we will have to rebase all of that as we go into the next year, because hopefully we will get into a position where we begin to fill some of these vacancies as the year progresses, and therefore will not have the same capacity. And then picking up Joe's point, it does mean that we need to engage internally now on delivering our own recurrent SIP targets, which, if you remember the previous version of the papers, we've got £5.88 million that we've asked the directorates to try and deliver recurrently this year.
Thanks for a clear summary of what is a very complex situation. Thank you.
Thanks very much. Sue, please.
being a slightly old hand at the NHS and the historical bits that go with some of the trusts that you've mentioned and how they have frequently never met their financial targets. That concerns me, and I'm pleased to hear how you said you will handle it for the future. But will there be any repercussions for those trusts who do not meet their targets? Because sadly, in the past, everyone else has bailed them out. And is it poor management or lack of funding? I know funding is never always the issue, but it does concern me that somewhere along the line, Oxleys may take the hit where others should. So that's just a comment, really. But thank you, Ezra.
So I think some of that, Sue, is going to be how well the Financial Recovery Board does work within the ICS. And I do know that nationally and regionally, they are keeping a very close eye on the financial positions. So I think this may be a changing environment as we move through into the new arrangements and exactly how this will be managed overall. But what we've said and what we're going to try and concentrate on is we do need to hold organisations to account for their own plans. And these plans have been signed off by their boards. So there is an expectation that they have to aim towards break even.
Thanks, Ezra. John, please.
Thanks, Andy. Ezra, I guess my question is linked, but it's probably more focused on the process, because your left-hand column had lots of deficits, and then the next column seemed to go into lots of positives. And you said that each organization went through a period of challenge. For somehow money was found after a period of challenge. My question really is around, I guess, what is a period of challenge? Who does it? And is it externally audited?
So I think there was a variety of different ways that we did it. There is still some work that we are going to be doing. During the pandemic, you'll remember we were in a different financial regime. And quite frankly, we were in a regime that whatever you spent, you were getting. And there was a lot of bolstering up of people's balance sheet, where effectively they were looking through their position, and especially if you were the likes of King's or Lewisham in Greenwich that had been in deficit for years, you were for the first time in a very long time able to bolster up your balance sheet and basically prepare for future years that you knew were going to be much, much leaner. What we were effectively doing through that process was we brought in a company called PA Consulting to have a look at benchmarking data to see how efficient were those organisations, and where they showed that there was a very large efficiency opportunity within those organisations, or where those organisations' cost base had risen very dramatically during the pandemic, we effectively said, you must have capacity to do more. Step number one is return to the same level of productivity as you were in 2019-20 before the pandemic. So that's where a lot of the challenge effectively came through for a number of those organisations. And what we said is you have to do more because it looks like you've got a lot less productive. And you were more productive than that once, so it must be doable again. That's the process that we went through there. The key challenge is now, can they deliver on what they've now said on paper they should be able to return and go through? That was probably the key element of challenge that we went through. And we used a combination of an external company and then us as a group of CFO and DOFs and chief executives to challenge each other internally, which in reality I think we will need to continue to do within the ICS.
Thank you, Ezra. If there's nothing else, thank you, Ezra and Joe. I know, Ezra, that not only you look after our numbers very well, but you keep a very close eye on the others as well. And I'm pleased that you leads us in these discussions with our colleagues to make sure that we're all on the straight and narrow. And Joe, thank you for your oversight of all of this as well. Well done, thank you. And we'll go back to item 6 now, please. Lead Governor report, Sue.
Hi, thanks. You've got a paper in terms of the lead governor's report and trust. I'm going to take it as read. to save time, but would be happy to take any questions. And I'm conscious that the afternoon goes very quickly.
No, well done, Sue. There's a lot in there. Thank you. It's very
There is,
comprehensive.
yeah. And it's just really to show some idea of what the governors do and how they get involved. And I think it's really good, and a big thank you to the governors for giving up their time to attend some of these meetings. And they always are very interesting. And I think the one that now I'd bring out and highlight is the Health Watch meetings we're having. That's really good, and we get a chance to ask questions. Certainly been good to be part of the NEDs and League Governors briefings over the last year for myself, and I found them extremely interesting and, you know, give you thoughts for the future. And obviously what I'd passed on to the governors is we are still hoping to have this Governors Away Day in October. So if you've got anything you want to particularly bring to that meeting, please let Joe or Anne-Marie or myself know. And one of the things we have to put on there definitely is cyber security, because I think everyone needs to be aware of that these days. And then the upcoming visits that are coming over the next few months. So, you know, it is part and parcel of our job as governors to keep the hold our non-exec directors to account individually and for the board. But it's been a privilege to be the lead governor, and look forward to working with you over the coming year. Any questions?
Thank you, Sue, and thank you to all. Oh, sorry, John.
Yeah, Sue, can I just add in, because I think there's two of us completed the health science investigation branch, that bronze training. There was 30 credits for the human factors, wasn't it? Systems, the new systems approach to investigations. So I think there's two of us completed that over the last 3 months. But I'll send you an email just to say that, yeah.
I rely on Joe to keep me up, and Anne-Marie to keep me up to date on what's going on with the other governors, but we can always make sure it's on the record. So thank you for that.
Thanks very much. Abby, please.
Thanks very much, Sue and Andy. So I just wanted to ask in terms of the membership committee, because I can see that you're chairing that at the moment as well. When are you likely to get a chair for that? I'm thinking of your well-being.
That's right. If we hang fire, so I'm not beating the membership paper, which is later on the agenda, I'll give you an update then. Thank you.
So thank you so much. Really, comprehensive account of activities, and I repeat your thanks to all of our colleagues, the governors, for the energy and enthusiasm you put into it. It's a really important role, and I think our Council of Governors does it with real aplomb. And thank you for your leadership, Sue, in all that. How's everyone doing? Would people like a 5 minutes? Nod or hands or whatever, or do you want to steam on? That's a stupid thing to ask a question. Loads of people like that, isn't it? Really. Let's have a quick. Let's come back at 15:45, please. It's a hot, sticky afternoon. You might want a quick refresh. 15:45, and we'll start again. Thanks very much. everybody. We'll make another start. We move on now to item 8, which I think is great out of hospital care. Abby, please.
Thank you very much, Andy. I'm going to try and share my slides, just a few slides to talk people through.
I'm just putting them up for you, Abby.
Thank you very much, Jo. Good afternoon again, everyone. I hope you're enjoying the nice weather and are keeping well hydrated. So I just want to give you a brief update on Great Out of Hospital Care, which is the second of our strategic priorities that the Trust have. For those of you who don't know me, I'm Abby Fadigba and I'm the Medical Director of the Trust, but I'm also the Senior Responsible Officer and I lead on this program. So next slide, please, Jo. So going back a few years now, because we've had COVID, people seem to forget that there was life before COVID. So in 2019, we had a number of stakeholder events across the Trust and with our partners and service users and carers to ask what they would like us to do, for what they would like us to concentrate on for the next 3 years. And there were various things that came out, and one of them was about people wanting to receive their care nearer home, and the majority of the care we provide in Oxleys, almost 80%, is for people in the community. So that is what people wanted. They wanted to have choice over their care. They wanted to be nearer home, while acknowledging that the populations of Bexley, Bromley and Greenwich are going to increase by about 10% over the next 10 years, and which will mean that there'll be an increase in all the different age groups across the 3 boroughs that we provide care to. So our vision was to be able to provide that care for people to have much more choice over their care, and for individuals to be able to access support when and where they need it. So right care at the right time by the right people. Next slide, please, Jo. So there are a number of things that we did after we started seeing the reduction in the number of cases of COVID, which was to get back on track to mobilise the things we wanted to do for the strategic priority. So this map may look a bit busy, so depending on how you look at it, it may be a wheel or it may be a pie. I like to look at it as a pie, so the different slices of the pie which correspond with our different directives. And because I like cherries, it's cherry pie. So Great Out of Hospital Care is a cherry in the middle, and that's what we're working towards. So over the next 3 years, there are a number of projects which we will be doing, and the culmination of that is a kind of Great Out of Hospital Care. The slide may be a bit too small and too busy for you to see the handwriting, but in each of our directorates, there's certain things that each directorate is doing for the cohort of service users that they're working with, which will ensure that people are seeing the difference in the care that they're being provided. So next slide, please. So we're 1 year into our journey, and what we've done in terms of trying to transform both our community physical health and ensure that only those who need our beds get to use the beds at the time, and to make sure that we've got a better experience for our service users. What we've been able to do so far is that in the last 1 year, in terms of our community physical health directorate, our urgent community response, which is a service that sees people who present in A&E or are referred by their GP, have been able to see people within the 2-hour target over 80% of the time. Most of the time we're at 100 or in the high 90s. Over the winter, we've been able to support young people who require intravenous antibiotics to get treated at home rather than be in hospital. And we've had very good feedback from the patients and their families. And this has saved a number of admissions and bed days to the acute trust. We've been working with primary care networks in Bromley, and we've got established mental health practitioners within the primary care networks now in all of Bromley. We're still recruiting into the ones in Greenwich and Bexley. And then we've started to set up mental health wellbeing hubs with the voluntary sector across our 3 boroughs, because it's not just about managing when you're mentally unwell, it's about preventing it and managing and trying to intervene early to prevent it becoming a much more serious illness. And there's some things that people need which the voluntary sector may be able to provide better support rather than them coming into secondary mental services. We've expanded the children and adolescent mental health crisis team to enable rapid access and intervention. I must say that one thing that has come up with most of the projects that we're working on at the moment, despite there being an expansion, we've all heard about the difficulties we have in trying to recruit. So staffing is a risk across all of those projects, and trying to recruit into the expanded positions that we've been given is a challenge. But having said that, the different project leads have been exploring different skill mix, different ways of developing people who are already within the services to ensure that we're meeting the targets that we want to meet. And for those of you who are not aware, we're going to have a conference on Monday to showcase some of these projects which have been taking place over the next year, and have a discussion about what our next steps will be and how we will start to expand what we do. Next slide, please. So this is just the slide showing what has been done in each of those service areas and what they've been successful at and what they will want to do going forward. So the CAMS Crisis and Intervention Pathway, their discharge pathway, has been nominated for an award, and I hope they win it because they've worked very hard with an increasing demand of young people that are unwell, just to make sure they're providing a good service for them. And as I spoke previously about the Home First Urgent Response, they've now had a fall service which they've taken on, which means that people who have had falls the team are able to go in and support them, which has relieved pressure on the ambulance service. So some of the work we are doing impacts the whole system, not just Oxley's, and we need to think about a way in which we can capture that impact. But from my point of view, the greatest impact is being able to support people at home without them having to have long waits, either waiting for another service such as the ambulance. Next slide, please. So that's just the flyer for the conference and exhibition on Monday, and those are my origami objects. I'm not sure whether to call them people, but the lady in the middle is the one that I tend to associate with. I like the way she throws her hair back. So I'm happy to have to respond to any questions that people may have. It was just meant to be a brief canter through. I'm happy to answer any questions.
Thank you, Abby. Any questions for Abby? If not, thank you very much, and we look forward to John, please.
Thanks, Abby. Abby, in your first slide, it says that the CMHT's caseload is the highest. Is it in London? I mean, that's quite a striking statement, isn't it? I'm wondering what.
Well,
is there one issue? Yeah.
I thought I had hid it in there, but well spotted. It's we got the data from the benchmarking, Nhs Benchmarking Data. It's multifactorial. Some of it may be due to what is on offer within the community, and some of it may be due to the level of expertise you have in primary care. But it's something that we're working towards with our voluntary sector and primary care colleagues, but it is historical, so it's going to take a while for us to start to reduce that caseload.
There's another hand there.
Cassandra, Andy. Cassandra.
Cassandra, please.
Hi, yes, thank you for that. I'm from Bridge, and we're part of the voluntary sector in the new community. Well, it's the Greenwich Mental Health Hub. It's just been confirmed as the name, so it will be a really new way of working. I think we're really excited to be part of it. Because it does represent a sort of fundamental shift from working kind of in silos and not taking enough notice of sort of social pressures in terms of kind of benefits, debts, all of the housing, all of those things that contribute. So we're really excited to be working with it. I do think that we would recognise, we're in the early stages, but there are some challenges around getting voluntary sector working alongside Oxley's, making sure that we all work in a similar way, but we are working well together to try and overcome that. So yeah, this does feel fairly transformational as and when we can get this all working, all actually co-located, which actually we think is one of the most important things, actually all to be in the same place to be delivering it. And then the other thing I will mention, the caseloads of the community mental health teams. Again, we provide supported accommodation and support people with mental illness in Greenwich, and we see the impact of large caseloads on the ability to the care coordinators to provide that care. So we really welcome the fact that we're aware that Oxley's are on the case, because I think that's fundamentally involved as well in terms of it's not going to help with staff retention or recruitment or all of those things. So we know it's all interlinked, and we know that we work best when Oxley's is at full capacity and we're at full capacity.
Thank you very much, Cassandra. I'm pleased to hear that there will be teething problems, but as long as we're working collaboratively to make sure we've got the best outcomes from the patient, that's what we're all trying to do. But thank you for that.
Thank you, Cassandra. It's really good to be working with you on this. Ravimbo, please.
Hello. Thank you so much for your presentation and for your oversight on the service user experience, better care out of hospital. I just wanted to understand, perhaps I missed the point, if you wouldn't mind covering it again, just in terms of what is the safeguarding around clients who are not accessing support, so those who are deemed not actually needing a bed, just sort of making sure people are not falling through the gaps, because I think my personal concern from the service user carer perspective is, whilst there is pressure on the staff, what's happening to service users who are not getting access when they need it, and just sort of like how service users are feeding back to you about vision.
Thank you very much, Ravimbo. We are still at the early stages, and the way the services have been designed now has been done in co-production with other service users. And what used to happen was there were various people that would fall through gaps, because it will be a case of you don't meet the criteria for secondary mental health services, neither is there anything for you in primary care. So it's those gaps exactly that we're trying to plug, so that it's a seamless pathway from primary care, working with the voluntary sector and working with secondary mental health services and making it fluid. So there shouldn't be a case of people not being able to access the care they need. So they will be able to access the care when and where they need it, and the appropriate organisation will be providing that care, because not all mental health or even physical health problems need to be dealt with within Oxley's, but we just need to make sure that people get the right care at the right time and in the right place. So it's the gaps that we're trying to plug.
Thank you. I would like to maybe have the opportunity to speak more with you.
That's fine. We can catch up. I'll get your contact details via Joe.
Thank you.
Thanks very much. And thank you, Abby, for that presentation. So we look forward to Monday. We move on to item 9, trauma-informed care. Noido and Emma, I think this is.
Hi, good afternoon. Thank you very much, Andy. Good afternoon, everyone. So thank you for inviting us to share what we are doing to integrate knowledge of trauma-informed practice in our acute and crisis services. I'm going to share my screen if that's okay. I know we've shared this slide back as a PDF. Let me just get the PowerPoint presentation up. Sorry about that. I seem to have clicked the wrong button for some reason.
Naidu, would you like Joe to share your slideshow?
I think it's just uploading. Let me know if you're able to see it.
That's great. Naidu, also, did you want to introduce yourself and Emma as well?
Thank you. Are you able to see my screen?
Yes, we can, Naidu. Thank you.
Okay. Okay. Yes. So I'm Naidu Omudon. I'm head of nursing working in acute and crisis directorate. I'll let Emma introduce herself.
Hi, my name's Emma Hopkins. I'm a ward manager working on one of the inpatient adult wards.
Thank you. So we're here to talk a little bit about work we are doing to train staff around relational security and how it links with trauma-informed practice. So we know we've got brief time, so I'm not going to go through all the slides, but hopefully give you a brief overview. So I'll take a few minutes to tell you a little bit about the training and then hand over to Emma, who will give an example of applying that knowledge in practice. So in terms of trauma-informed practice, we are training staff to understand and take an approach to recognize the impact of trauma and adverse childhood events on adults, how it affects the individual's sense of self and the way that then it affects their ability to be able to connect with and use our services. So the principles is shifting the way that we ask questions, so key messages about asking what has happened rather than what is wrong, and training staff in inpatient around integrating knowledge about trauma in all aspects of the practice, changing our operational policies, and training staff to recognize the signs and symptoms of trauma and how they minimize the possibility of re-traumatization. So there are some obvious practices within our inpatient setting that could be re-traumatizing, things like use of restraints, isolation, and there are some less obvious situations. For example, sometimes specific smells, sounds, or types of interactions may cause individuals to feel re-traumatized. So the 5 guiding principles are safety, choice, collaboration, trustworthiness, and empowerment. And this is built into the training we do around relational security. I like this visual picture of the impact of trauma, how it affects a person's mental, physical, and social outcomes. And the statistics are staggering in terms of 56 to 68% of children experience adverse life events, and how that impacts on their sort of mental health and risk around suicide attempt and the access and their needs for service. I won't go through this slide, it's just for information in terms of impact of domestic and sexual abuse on mental health. So the key part of the training that we're rolling out to our inpatient team focus on relational security. So I'm part of a London-wide project, the Safety in Mental Health Settings project that's offering training for facilitators in relational security. So in Oxley's, we have 5 facilitators who were trained in May. And by September, we're looking to add another 6 to that. So we will have a core group of staff who are embedded in the team to implement that approach to care. And Emma is one of the facilitators who were trained in May. So with relational security, it's about our approach to safety, our attitude to the people that we care for, and our understanding in terms of what is going on around us, and using that awareness in the most therapeutic way possible. So you can see in the wheel there on the screen the 8 areas of therapeutic practice that is covered in the model, in the framework. And it's called See, Think, Act because it gets staff to reflect. And see means looking at what's happening in the service, listening to what people are really saying. And think is about thinking about the implication of what they have seen and heard and what the most therapeutic options are. And act is about taking course of action that has the most therapeutic benefit for that person, for the situation and the safety of others. So trauma-informed values are integrated in each of those segments of relational security. When we do training for the facilitators, it's a free full-day course. So we go into a lot of details in each of those segments. For training in teams, we're looking at half-day workshops, full-day workshops in teams to be able to go through in detail looking at each of those segments. So the time today doesn't allow me to go through each of the segments, but I'll give an overview on a couple of the segments. So around boundaries, the training look at how we introduce boundaries. There's procedural and professional boundaries, but getting staff to think about what the rules are, the therapeutic justification for the rules, how we apply the rules flexibly, and what consistency means, consistency between staff and how we are able to use judgment to flex boundaries. So we get staff to reflect on that, because with consistency, it doesn't mean doing the same thing all the time, but it's thinking about the need of the person and being able to not use blanket rules, but to negotiate. And what are the principles we use to negotiate. So there are a series of exercises that we use to get staff to reflect on practice. And taking on board the principles of trauma-informed practice around safety, choice, collaboration, trustworthiness, and empowerment. So how previous relationships can affect boundaries and the way we maintain boundaries with others. And the importance of staff, I think, being able to fulfill promises that we give so that we can build trust. So that's one element around boundaries. Therapy, again, we get staff to reflect and think about from the perspective of the patient, how it feels to arrive in the service. What would they be worried about if they were on the ward? What would they miss? And how does it feel like being on the ward? So understanding people's trauma, looking at collaboration in the way that we do care planning. And this is an important slide, looking at the way that we do risk assessment, more importantly, safety planning. So as part of our assessment, getting staff to ask a question around, it's I suppose, sometimes staff are afraid to ask about trauma. And sometimes people feel that they are not trained therapists, so they're not able to ask those questions. But I think the key thing in the training is to be asking the question about what has happened in the past. But the person may decide to tell us or not. But the key things we want staff to do is to be able to say that they understand, they validate the sense of validation for people, and give a sense of belief to the experience that they are sharing, and how we can keep people safe, and understand who already in their social network in their life that they can trust, and moving from risk assessment to safety planning. So there's information I put in there on patient mix and how that link with trauma, how the group of patients on the ward can impact and can be triggering, and for staff to understand that and being able to respond. And in personal world, again, that's key to how we understand and how we communicate with the patients, understanding how they might be feeling, how trauma is relevant, are we doing enough to be able to support, how we manage difficult situations, how are we communicating in a therapeutic way. So going into a lot of details through exercises to get staff to practice some of the difficult conversations, and reflect using feedback. So as part of the training group, we do have lived experience practitioners who join the training, and also we are looking at replicating that within Oxley's when we do the training, to look at having people who have had experience of using service to join the training, to be able to give a service user perspective to the training. The impact of physical environment. Again, because of time, I won't go through the details, but those are the elements. I'm going to pass on to Emma to go through an example of applying that knowledge in practice. Emma?
Hi, so I'm going to quickly talk through the application of the C-Think Act framework and provide an example of how it's used in the ward to ensure that a trauma-informed approach is applied. So I've changed the name of this case study for confidentiality purposes to Miss B. So Miss B had been on the ward for a few days, and staff identified that her presentation was complex, where they were struggling to understand how best to support her. So in brief summary, Miss B was a 55-year-old woman who was under the care of mental health community team. Up until March of 21, she hadn't ever had an inpatient admission. However, this was her 7th admission in just over a year period. In 21, she was diagnosed with generalised anxiety disorder, dependence disorder, and emotionally unstable personality disorder. For this admission, there was a decline in memory, concentration, and ability to undertake everyday activities. She was expressing suicidal thoughts and had attempted to take her own life. Next slide. So on the ward, she was incredibly distressed. And language is really important. And sometimes the language we use can evidence that clinicians are struggling to apply a trauma-informed base to a patient's care. As I said, my team identified they were struggling to understand how to support her. And language you might sometimes find used for these behaviours are words like demanding for attention, lacked motivation to work with the team. So this patient, she could become aggressive, and a lot of language that we would often hear is that she was challenging, especially when immediate needs aren't met. And when they were met, she was still resistant to work with the team. As you can see on this slide, there's some negative words that identify requirement for a trauma-informed approach. These terms instruct that the patient is in control of their responses, which we know often is not the case. Next slide, please. So a person is more than just a patient on the ward, and this framework is used to help us structure what we know about a person. So we placed our patient in the centre. I ran a clinical reflection with the team to help them identify and consolidate the information they already knew about Miss B. So it's not about me giving them new information, it's about looking at how we're using the information we already have. So personal world, who was she? What was her experiences in life? How did she view the world? So we knew that she was a mother, and this was a large component in her life. She previously was a full-time carer of her adult autistic son until a year ago when he was moved into a residential placement. This was around a time that her mother passed away and a child in the family was diagnosed with leukemia. Staff were reflective around the trauma of loss and personal identity. And a year ago, when she first came into inpatient services, the team reflected on how these traumas might have impacted her responses to situations that she was facing. We knew that she had physical health issues, which compounded her journey. So she was under a neurologist with suspected chorea and underlying physical health issues. And the team reflected on the trauma that can cause someone when they're undergoing potentially life-altering physical illness. The physical environment aspect. So the ward was loud, lots of shouting. Staff surmised on what her household might have been like if her son might have been high sensitive to noise. Was she finding the noise levels uncomfortable? Was this a potential trigger? Where on the ward was she most comfortable? So we knew that she liked her bedroom when she was feeling upset. Staff knew that if her light was off, that meant do not disturb her, as she liked to rest during the day. That included not being woken for lunches. She used her use of the environment to communicate how she was feeling when she wasn't able to verbalise what she wanted. Outward connections. So her daughter was involved, and Miss B would often spend time waiting by the door to see her. What we knew there'd been a large shift in family dynamics, and recently with the bereavements and the move of her son, we discussed the impact that might have had on the family and the daughter. So we looked at what the daughter's support needs were. So carers assessments that would be needed, carer support groups, and also how we could use Teams and technology to support the daughter visiting her mother remotely without even having to travel. Either way, grounding Miss B to her support connections was identified as necessary. The trauma of disconnect from family whilst an inpatient, as well as the trauma of a patient experiencing rejection when visits don't occur, was also discussed with the team. What other support would be needed in place for the community follow-up also occurred, so telephone befriending, what was needed in social prescribing in the community. So this went on, we carried on with the cycle, and by this point staff were able to adjust their viewpoint to understand what was driving certain behaviours, and we worked through the Relational Security Explorer to identify what the team needed to better support Miss B. So we know people who experience chronic trauma often develop survival strategies to manage traumatic experiences. So their brains and bodies adapt on these experiences in ways that can be sometimes misinterpreted by others. So using trauma-informed language places the onus of support onto the team and identifies what care plan and intervention is required, opposed to using a negative language which only serves to label the patient without any benefit to the patient. So when we change a narrative, Miss B, rather than being seen as manipulative, she was getting her needs met in ways that have worked for her in the past and doing whatever it takes to survive. With regards to disrespectful as a label, so that's someone who's feeling threatened, unsafe and out of control. Attention seeking, it's someone who is feeling unheard and looking for connection, so someone who's feeling disconnected. And unmotivated is someone who's feeling overwhelmed, depressed, fearful and frozen. So that gives us something to work with in order to tailor the interventions we're using to support that person. Next slide. So once we've done that, we're able to form a relationship with a patient whereby we're supporting them. It did help. So we know that trauma-related behaviours can be frustrating for the staff working with patients as well, but they make sense in the context of someone's experiences. So when we put on our trauma glasses, we consider the role that trauma might be playing. We start to think and talk about patients and the behaviours differently, and it does impact the relationships that we're having. So this is just one example of one of the ways we're using the relational security C-Think Act framework.
Thanks, Emma. So, as I mentioned earlier, I think we at the early stage of this, so we have got facilitators, 5 facilitators now trained. Our intention is to give those facilitators protected time to be able to do induction training with teams and also be able to support development sessions. As we mentioned before, that I think the challenge with turnover of staff and difficulty with recruitment and retention, being able to have enough of the team trained up so that we can bring new staff in and still have a level of knowledge in the team to be able to implement those approach. But being embedded in the team means they are part of the team. They can participate in reflective practice, case conferences, be involved in discussion around review of incidents, and also look at supporting staff in supervision and through development workbook to further enhance knowledge around that. So sorry it's rushed, but hopefully it's given you an overview of the work that we are doing within the inpatient and crisis service around trauma-informed approach through relational security.
Now I do, and Emma, thank you so much. It was really, really good. Thank you. Claire, please.
That was a really, really good presentation. Thank you. And I think it's literally life-saving for service users and carers. I've been sitting here scribbling loads and loads of notes, so I hope I'll make some sense. When you talk about safety, empowerment, collaboration, choice, and trustworthiness, one of the things that comes up for me as a speaking to service users and carers, especially in the neurodiverse and SEND world, is around accountability. It comes up time and time and time again around accountability, because one of the things a lot of parents and carers have said to me is they get triggered by professionals. So people who are, whether it's in, a social worker or, other local authority staff or, various other staff who are not trauma informed. And actually, you talk about re-traumatization, and it happens an awful lot. So I would absolutely love to be involved in anything else that you're doing, because I can't tell you, this is absolutely life-changing work for service users and carers, but absolutely fantastic.
Thank you very much, Claire. Thank you for that. I mean, Millbrook Ward was part of the pilot when we did this last year, and we can see the difference it makes in terms of the feedback that we're getting, but also response that we're receiving. Certainly we are seeing patients who, if admitted elsewhere, will have longer length of stay and sometimes are needing to go to PQ where they've been on Millbrook Ward, they have been managed within acute services. So it is early days, but it's an interesting space to watch. Yeah.
Thank you. Ravimbo, please.
I'd like to second that. I think this was a fantastic presentation. I feel that this is what Oxley should stand for and stand behind, and be able to replicate not only in trauma, but in sort of other direct care provision for its service users. But this is something that I really hope that practitioners will be able to take on board in a constructive way. One of my concerns, again, has been that in owning the discussion about recognizing that professionals can be in themselves triggering, is to put up blockades to then prevent the service user from actually being able to recover. So rather than trying to deal with the fact that there's a trauma process happening between the practitioner and the client, some practitioners perhaps will prevent the opportunity for encounter with the service user, if that makes any sense. And again, this is something that Oxys does need to take on board. But fantastic presentation, fantastic goals, and really supported.
Yeah, well
said. Thank you very much. Thanks for the encouragement.
Yeah, well said. Thank you. John, please.
Thanks, Andy. I think Emma and Nadu, can I just ask you about whether or not there have been any developments about staff themselves having to recognise their own traumas. Because in a way, if they're the catalyst for trauma for others, I suspect there's something internally for themselves. And I guess that has implications for the trust wellbeing services. And I wonder whether there's any examples or any opportunities you've had.
Thanks, John. Yes, I think secondary trauma experienced by staff. So a big part of the practice is also reflection for staff, opportunities for use of reflective practice, use of discussion about how elements of personal world impacts on staff, the impact of incidents on staff, and how we look after our staff, so staff well-being, also psychological safety in teams, so being able to feel safe to talk about difficult situations. So yeah, I think it's so interconnected with a lot of the things that the trust is trying to implement around staff well-being to make Oxley a great place to work. I think it links in a lot, and I think encouraging staff to be able to recognize those signs and talk about them and provide support. Thank you.
And well done. I thought that was really superb and great piece of work. And congratulations for everything you're doing. We look forward to hearing more about this in due course. Thanks very much, Nadia and Emma. Thank you. We'll move on now, please, to membership and Sue.
As I start off the presentation, as Amber already, we have a new chair. Somebody very rashly volunteered at the last meeting, and that's Sarah King. So it's lovely to know that she's willing to take that on, and thank you very much. I fully appreciate that. We're going to have a Teams meeting together next week just to discuss things, and so I'm quite relieved to have that. Didn't mind sharing it, but it adds to the other bits and pieces. So I always believe in sharing the workload. So I'm very happy for Sarah to take that on board. The work stream that we've got for the membership committee is getting there slowly. Some of there have been slight hiccups in terms of the young people's work, because obviously that's put on the back burner for the moment until the new term starts in September, October, so we can actually move forward with them rather than now. The transit in prisons one, that's a slightly different issue, is that because the people we would like to be members are, it's difficult in terms of the constitution for Oxley for them to be members, and there's a whole load of issues around that. And whilst we'd like to do that, we thought the suggestion is that we would concentrate on forensic services due to the limitations with the prison service, because people who are coming out of prison and improving and moving forward, there might be more of an opportunity there. The one thing that we are looking at, and we did have quite a lengthy discussion with, and Sarah had a few ideas, so I'm waiting to hear what she has to say when we meet next week, is looking at opportunities at other ways for the governors to be involved in what's going on and the wider public. And so we're looking at different things, because sometimes you don't always get to know about these things until it's too late to sort something out. The classic was the Make Merry at the Plumstead one, because by the time we knew about that, it was too late to get anything organised. But we're looking currently at having some sort of stall or table, if we can, at the Lark in the Park. And so I'm going to get in touch with the organisers, because I do know the people that organise it, and see if I can track them down and just say, could we have a stall and where could we be? Not every day of the week, because it is every day, so we might just decide on a day and then see what we can do. And having listened to the presentation on great out of hospital care, I'm going to that, and I know some other people are, so it's a good opportunity to get involved and meet people. And there's also the volunteers event in July, which I had hoped to go to, but I'm already doing a NHS providers day. So I'm sure there'll be some governors and other members who can attend that, because I think the more we can put Oxleys out there into the public's mind, we will attract more people to become members. And I don't think they always appreciate just how much work Oxleys does and what they're involved in. And again, I think a lot of people see Oxleys as a mental health trust rather than other things like the things that we do, or Oxleys do, and I'll use a royal we, in Queen Mary's, for instance, with the outpatients and all the other avenues in there. And I think it'd be good to get them to understand how just involved and what a vast network there is that comes under Oxleys. And it's just encouraging people to get involved. And I think now we'll come, well, out of the pandemic, we hope, properly, or will be eventually. I hope we don't go into another one. It's getting people involved and seeing people. And I think that's the more we can get out there, the better. So, and one last plea to governors, excuse me, is to make sure your profile is complete on the website. That would be handy. So it's be a good opportunity to get Oxleys out there in the wider population. And I'll stop there before I cough because my hay fever's playing up. So any questions?
Thank you, Sue, and well done, Zara. Thank you. Any questions for Sue at all? If not, then very grateful for the work that's been done and look forward to you chairing that. Then Zara. Move on to the Constitution, and Sally, please.
Thank you, Chair. So this paper brings some suggested updates to our Constitution. So if you remember at the last Council of Governors meeting, we flagged about having to review our constituencies because of the changes in the directorates. And thank you to Tina and Rebecca, who joined us as a small working group to have a look through. And in the paper are the recommendations from that discussion, which is to update our staff constituencies to align with our new directorates, and so that will make it easier for those colleagues to represent colleagues in those directorates. We also have had a look at the Constitution in light of the new legislation that's gone through, which has removed Monitor and created NHS England and created the integrated care system rather than clinical commissioning groups. So in your pack is a marked up copy of what we are proposing would be changes to the Constitution, and we're bringing those to you today for your approval. If the Council of Governors approves it today, then we will then take it to the Board of Directors for approval and then can publish this as our updated Constitution. Just before we think about whether we're approving that, I just wanted to flag up that there is a new code of governance out for NHS and foundation trusts, and this is out for consultation and is likely then to come into operation later this year. And we will need to review our Constitution again against this updated guidance to make sure that, again, we move in line with the sort of national changes. There are a couple of bits more in the report, but I wonder whether to stop there at the Constitution part so that you can raise any questions with me.
Anything for Sally on the Constitution? Sally, do we have to approve this at this stage?
Yes, that's one of the, there's 3 recommendations in the paper, but this is the first one. So yes, if we could formally approve this, that would be good.
I propose that we approve the changes to the Constitution. I shall take silence as acquiescence. Unanimous, Sally. Well done. Thank you.
Thank you. And again, thank you to Tina, Rebecca and Joe for your support and work on this. Then the other recommendations in the paper, one is just asking the governors to note the summer elections that will be taking place. And finally is to bring back a recommendation to the Council of Governors following the survey that we held earlier this year about whether to hold meetings, continue to hold meetings virtually or to meet face to face. And we've analysed the feedback, and from the information that people shared with us, then we're proposing that we continue to hold Councillor Governor meetings virtually, but then have an annual Governor Away Day in person, which then enables people to network, and things like the annual members meeting we will aim to have in person, assuming there are no further social isolation issues. The board has also gone through a similar process and has decided to continue to meet virtually, but then to have informal meetings in person. So this final recommendation is asking the Council and Governors to agree to that, to continue virtual meetings for the formal meetings. Thank you.
Yeah, thank you, Sally. Now, obviously, we had a lot of discussion and the consultation that Sally's talked about. I must admit my initial thoughts are we're all going to get back to where we were, but it was quite interesting to hear people's views about time, cost of travel, which now is probably even more of an issue. Definitely the environmental issues as well about reducing travel. And that seems to be fairly strong views across the board, as Sally has already described. And there are lots of benefits to this. We're much more public, in the sense that people do tune into these meetings in the same way they do to the board. So we're reaching more people. And I don't know how our colleagues are finding it. It was great the other day when we had an informal board and we all got together, and it was really good to see people. It was excellent. But as far as the business meetings are concerned, I'm finding that they're working pretty well. And obviously I'll be interested in views, but the suggestion is, as Sally has said, that we will continue remotely, other than the annual one and the members' meeting. So, any views from anybody? We have sent it out for consultation. So, to be frank, I'm not looking for a redoing discussion. If anyone had any points to make at this stage, otherwise, I'll just ask for your agreement. We will review as time goes on, without a doubt. John, please.
I just wanted to comment on Pinewood House, Andy. I was there last week for a face-to-face, and it's changed completely, isn't it? The ground floor in, in cafe style presentation, really, and sort of agile working clearly being the future as the investment within that Pinewood House.
Yeah, it's really interesting, actually. It's quite a shock at first, isn't it, when you see it?
It was a shock when I saw it, and I thought, goodness me, but I thought you just need a nice little cafe now there in the corner, thinking that's...
Yeah, I
could work with that.
We could certainly do with something there, but I mean, it's really interesting. So I'm interested to see what Ifrs got to say.
Yeah.
I was just going to say, John, I'm glad you noticed, right? A far cry from yesteryears, and the cafe will come along before long. Yes, now it has changed, and I think the really exciting thing is that we're really encouraging colleagues from other parts of the trust to use this space. So if you think about acute and crisis, for example, I think they're there at least once every week or twice every week. They actually hold their senior management team meetings there, face to face. And that's not what we want to do. We want to move away from Pinewood being trust headquarters where we all sit, etc. But actually bring clinical teams to Pinewood. If indeed it's more, if it works better for them, and I really get quite excited when I see people using it for their team meetings and for team discussions. So we've opened it up, and it looks really great.
Thanks, Iffy. So, I mean, I think we'll continue in the way that's been recommended, and we'll review in due course. And people are obviously welcome to, send any further comments in they've got. Thanks very much. Anything else, Sally?
No, that's it. Thank you, Chair.
Well done. Thanks ever so much for all the work that's going into that. And the last item now, I've got quality accounts and Vicky, I think.
Thank you. So my name is Vicky Woods. I'm the Associate Director of Quality Assurance and Improvement for the Trust. And I've also got Victoria Sappin here with me today, who's going to give a small presentation on the quality account, because she had the delightful pleasure of producing these accounts this time. So I'm going to help out with the questions at the end. Over to you, Victoria.
Good afternoon, all. Let me just share my screen, if I can.
Joe shared it for you.
Oh, okay, thank you. Makes it easier. Thank you. Okay, so over the next 5 or 6 minutes or so, I'll be discussing the highlights of the annual quality accounts for 2021-22. And at the end of the presentation, there'll be an opportunity for any questions that you may have. Next slide, please. Thank you. So today I'll be covering progress against the 2021-22 quality goals, and we will be informing on the quality priorities set for 2022-23. Also, just to note, and as you may be aware, the annual quality accounts follow a prescribed statutory format. So practically, this means that the order of the report, the subheadings, and in some sections, the wording structure is predetermined. When we come on to the next part of the presentation and we consider progress against the 21-22 quality goals, I think it's important that we hold in mind the pressures and restrictions created by COVID and the impact that this has had on the achievement of some of these targets. These targets will, however, continue to be taken forward by the Trust, and we endeavour to achieve these and to sustain performance as we move through 22-23. So the next slide, thank you so much. So performance against the 2021-22 quality goals is broken down by quality domain, and this slide details patient experience outcomes. So you can see here that 2 out of the 4 indicators have been achieved, the 2 highlighted in green, with a third indicator 5% away from the target but improving. If you could click your mouse, 2 lovely charts will appear. Thank you so much. So with the charts here, you can clearly see some of the trends that have developed. So with chart 1, the first chart, you can see the blue data line increasing towards the green target line, tracking the improvement that is being made. And with chart 2, you can see with the blue data line, it exceeds and moves through the established target. With the first 2 indicators that we have yet to achieve, work is continuing with services, clinical staff, service users to optimise outcomes for this year, 22-23. Further, a project is taking place to analyse the free text responses from patient experience feedback, and it's expected that this data will further allow us to understand potential improvement areas that are important to our service users. Next slide, please. Thank you. So moving on now to the patient safety priorities. For 3 of the metrics, we are almost there with meeting the targets. And if we click the mouse, we'll see some charts which help us to illustrate this and the progress made thus far. So with the chart 1, the top chart, a downward trend is what we are looking for. So we can see that improvement here is moving in the right direction. And with the second chart beneath that, we can see that performance is improving towards us meeting our target line. For the first indicator here, the one displayed in red, the use of restraint in 21-22 was consistent with the amount of restraint recorded in the previous financial year, and use of restraint does continue to be monitored through the patient safety group. If you could click your mouse for me, please, we can see here that it is noteworthy that we're considering that the current percentage of prone restraints as a percentage of overall restraints are in fact at the lowest level ever recorded in Oxley's. So I thought that was certainly worth highlighting. Thank you. In the next slide. So moving on, we can see the final quality domain, which is clinical effectiveness. You can see that of 4 indicators, 2 are just shy of meeting the target. And we can see that indicated by these 2 charts. Yeah, there we are. Perfect. Thank you so much. And specifically for indicator 3.4, the second of those 2 charts, we continue to see that sustained improvement. So moving on now to the quality priorities for 22-23. These priorities reflect the diversity of services that Oxley's provide, and we've worked in partnership with our staff, service users, carers, members, commissioners, GPs and others to identify these areas for improvement. And following consultation, one overarching quality priority has been identified from each of the 3 quality domains, and these form the overall trust quality priorities. Directorate quality goals have also been selected, And these these relate to these 3 quality domains. The Trust quality priorities and Directorate quality goals will inform the quality improvement efforts that take place throughout the year 22-23. And the next slide details the quality priorities that have been agreed. These quality priorities follow an established governance structure that monitors and measures performance and progress, and this happens quarterly at a minimum to the Trust's Performance and Quality Assurance Committee. The next and final slide details the Directorate level quality goals that have been selected and indeed how they relate to the 3 overarching quality domains. So metrics around the specific improvement efforts related to these quality goals that have been identified are currently in development. We're 80% of the way there, and we are on target to have 100% completed by the end of June, which was our target. Come the end of June, and at this point, efforts will then focus on driving these improvement efforts. Okay, and the next slide, please. Thank you so much. So I welcome any questions. As Vicky would say, she's also available to answer any questions. I've been on maternity leave for the majority of 21-22, so Vicky will probably be better versed than I to answer many of your questions. Thank you so much.
Well, thank you, Victoria, and welcome back, and thank you, Vicky. Any questions at all? That was really helpful. Thank you. John, please.
Can I ask, are you able to change the language, I wonder, within those quality indicators? Because we've just had a session on sort of trauma-informed care, where they were discussing risk assessments alongside use of safety planning. And I'm wondering whether or not it was possible to align perhaps those 2 together, whether that would be beneficial.
The quality goals and the quality priorities have been set by the directorates themselves of what their priorities are for each of the different areas. The language that we use within them is in our gift to change. So we can use the different type of language when we're setting the actual goals for each of those areas. So at the moment we've got themes for each of the areas. So we can speak to the directorates, and when we're setting the metrics and the goals for achievement, then we can look at how we can inform that within that sort of setting. Yeah. Thank you, John.
Any further questions at all? If not, again, Zara, please.
Hi, yes, thanks for a really interesting report and a lot of details in the papers as well. I was interested to ask, maybe this is more of a question for the board, but how do we feel the organisation is performing in terms of having a sort of culture of quality and quality improvement?
Do you like me to answer that? So I've been trying to introduce, as part of our building blocks, is the quality management framework. So over the last sort of year and a half, we've really been trying to embed that and develop the infrastructure around the development of the quality management framework. So for example, for quality assurance side, we've been looking at introducing the improving lives reviews. We've been looking at introducing a new NED-led review process to have more assurance functions. With improvement function, we're looking at increasing our ability to look at all improvement as a whole, rather than just looking at QI as our methodology. And also within quality control and quality planning, we're looking at using our information understanding. Sorry, my dog's going mad because the door's just gone. Apologies. And using quality planning as our sort of methodology of understanding the needs of our customers, to making sure our priorities are set based on what our customers need and what our population needs. So we are trying to embed a culture of continuous improvement through that methodology. And I think maybe Abby might want to come in with some additional thoughts on that, or if he might want to come in.
Thank you.
Yeah, I was about to say quality is what we do. So it runs through the thread of everything that we do in Oxley's. And I can say that because I've been at Oxley's for 17 of the last 20 years. So it is, we've done it in different guises, but it is always at the centre of what we do. So we started on a journey of quality improvement using a specific model, which was the model for improvement. But we've also recognised during this period of COVID that people have been doing some rapid improvement cycles. So we're trying to get our quality journey to progress to the next stage, to include everything: quality improvement, audit, and as Vicky said, quality planning, assurance, and control. But in addition to that, there's also things like research and making sure that we do much more with our service users in terms of what do people want us to do, what do they want us to concentrate. So it's a thread of what we do all throughout.
Thanks, Andy. Yeah. Stephen, please.
Yeah, thanks, Andy, and thanks, Sarah, for the question. The other thing I would also mention, in addition to what Vicky and Abby have said, from an internal auditor point of view, we have this year looked at data quality around waited list management, and also for this year coming, 22-23, we've got one coming up on the back end of the year on patient safety data. So that's quite useful to sort of back up, to give us some assurance in a measurable way that kind of the data going through the system is reliable, and we can see some, hopefully see some good outcomes being achieved.
Thank you, Stephen. Anything else to anybody else on that? If not, Vicky and Victoria, thank you so much. Really, really good. Thank you. And we look forward to updates from time to time on how we're getting on that. Is there any other business from anybody? I haven't been notified of any, but I don't see any. I just want to thank everybody. I thought that was absolutely super meeting. You know, lots of involvement and great presentations. And big thanks to our Council of Governors for all the work that you do. To our exec, you know, working so hard. We see this firsthand, just how hard everybody within Oxley's has been working through some really, really challenging times. And thank you to everybody for a really good meeting. Very grateful. And we'll see you again, the Council of Governors, on the 15th of September. Thanks very much. Bye-bye.